You're muted.
I still haven't learned how to use Zoom, looks like. So no, I was just saying that was great about this kind of debatable concept of using an endo loop and clip, but looks like their 1 year follow-up suggests that the wrap is intact in many of these patients. So the question we have from the audience is TIFF a good choice over Poem F? And I think if Ken Chang is still here, yeah, Ken's there. So Ken, you want to take this question?
Boy, so I've been following Dr. Inoue's work with this with great interest. So I have a few thoughts. One is technically this is quite difficult, advanced, and being out in the peritoneum, putting clips on endoloops or single hand suturing is not for the faint of heart. So I think technically it's difficult. But beyond that, I mean, obviously it's cool to see, but just going back to principles that we've learned about GERD and surgery for GERD, my question would be, the real advantage is that you can potentially do it on the same procedure as the poem, but the same argument for TIFF with every poem is the same question here. Do you need to do it on every patient? And if you don't, then the advantage of coming back later to do this doesn't make sense if you can do a laparoscopic hernia repair, even quicker than this and arguably safer and more effective. So that's one point. The other point is, we know that if we look at the Heller, the history of Heller and Heller alone, then Heller plus partial fundo, the majority of partial fundos now with Heller is a toupee, not necessarily a door. And then if you look at long-term, which will decay faster or which has the chance of not being durable? Is it that myotomy or is it the fundoplication? And it's clearly the fundoplication, which doesn't last as long as the myotomy. So now you're doing an endoscopic, with endoloops and so on. We don't have pre and post pH data from this series. I think we just have the post pH data. And I would say, I would wonder if the durability of this as an anti-reflux will have a long shelf life. And then what happens in 5 years when the patient has bad GERD? Then you need to go back in and do a proper laparoscopic repair. So I wonder about the selection. I wonder about simultaneous. I wonder about effectiveness, and I also wonder about durability, especially when we have TIFF. I don't see this being something that we're going to do often. There may be select patients, select situations, but as cool as a procedure as this is, my bet, and I guess I'm getting old, is that this won't stand the test of time. But I'd love to be proven wrong.
Right. So I agree with you, Ken. I think there's a lot of issues with this procedure, and the reason I asked Dr. Bape to share this video is because he has one of the largest experiences with doing this procedure. And I spoke with him this week since he was not able to present it live, and there were all these questions. So you're absolutely right. The main concern is how durable is this? Whether an endo loop on the serosal aspect is going to be enough to hold the fundus wrap for a long time. We don't know that. So I think that's the first thing. The second thing is that technically, after speaking with Dr. Bape, there's a lot of nuances and learning curve. And even in expert hands, and he and I were talking, and it also took them a few procedures to learn how to do this without any serious adverse events. Not just that, the endo loop that is available in the United States, if that were to be used for this procedure, you need to have that endo loop outside of the scope and catch it with a clip that goes through the channel of the scope. And that has to go through the tunnel into the peritoneum. While that is going on, an XP scope or an ultra thin scope has to be in the lumen of the GI tract, retroflexed in the stomach. So there's very little space. And he and I were talking, and he said the same thing, that it's not easy to do that aspect of the procedure, but it can be done. It's technically more challenging. The second thing is that they are using a different kind of endoloop, which he mentioned, which is available, I think, in Asia, not here, which is detachable, which they just catch the endoloop, not the whole sheath, and they can just go with that, which makes it much easier. And then it has a larger hook that they can just hook and then, tighten the endoloop. So there's a lot of technical issues with it. Every patient does require an abdominal needle to decompress, because if the intra-abdominal pressure goes up, not just the effects on the hemodynamics of the patient, but that causes the omentum and the peritoneal fat to start coming into the myotomy and into the tunnel, which makes visualization exceedingly difficult. So there's a lot of technical issues with it. And I think for our patients here, we would not probably be able to adopt it right away for various reasons. One is not just the technique, but just the question about the data for long-term effectiveness. And then the other thing is we do have other options like TIF, which we can provide as needed. I did ask Dr. Bape about options for doing TIF or some similar procedure in that part of the world, and they do have GERDEX. I don't think they have TIF, and I think there's a big cost difference where the device, the GERDEX device, is way more expensive than adding on the F part in the POEM F. So I think there's many reasons why they do it in that part of the world. But I agree with you. I don't think we're ready for it right now. So I'm just checking to see if we have any other questions on this. If not, I think we can move on. And I think our next video case is going to be from Dr. Aihara. You've already heard Aihara earlier today, and he's going to be showing us a case, ESD with track motion.
Can you see my screen? Hello?
Yes, we
okay,
can.
Perfect. So I have one case that I performed very recently. When was it? So it's November 1st. I have used the this track motion device for probably 6 or 7 times, and then I have been seeing its benefit and some downside. So I'm going to show the case where I use the track motion. So this is the probably approximately 5 to 6 centimeter bulky mass found in the rectum, approximately 25 centimeter from the inner verge. As you can see, I did the BLI. This is the NVI, the same as the NVI technology from Fuji. So this is the oral side of the lesion, and then I did the magnifying BLI, but I did not see any invasive pattern. So if you want to use the attraction technique, so basically we need to finish the full circumference or mucosal incision first. This is because if you do not finish the incision at the oral side of the lesion, you won't be able to finish the incision at the end. So usually in the colorectal ESD, we've been trying to avoid any full circumferential mucosal incision to avoid any leakage of the injected solution. But if you want to use the traction technique, the basic principle is to finish the full mucosal incision first. So I'm using 1.5 millimeter Ori's Pro knife. And then the advantage is that during the mucosal incision, as necessary, you can start add some injection because the injection comes through this needle. So you don't need to retract the needle when you do the injection. So after finishing this mucosal incision, the next step is to use the track motion. So you need to switch the scope with the double channel upper endoscope equipped with the track motion. So we've switched the processor from Olympus to Fuji. And then as you can see here, the picture is very good. And then even for this double channel endoscope, the picture is still good. It's not the high def, but it's something we can use for the submucosal dissection. So I'm going to introduce this track motion device, which has the articulating grasper. So we can go up and down, and then it's a 360 rotatable, and then it's a physician controlled device. I'm checking the direction and the force, and then to simulate how I can start dissecting. So basically from the right side of the channel, I'm using the track motion, and then I'm using this clutch cutter 5mm from Fujifilm for the submucosal dissection. So the advantage of this scissors type ESD knife is that we can perform the prophylactic hemostasis, which we call vessel sealing before dissecting. So as you can see here, I can adjust the height of the attraction by using this track motion. And then we can change the angle depending on the dissection plane. So I got some bleeding, but the good thing is that we can use this scissors type ESD knife for the hemostasis as well. And then because we have this traction, we have a good visualization of the bleeding point. So we no longer need to use the distal attachment cap because we have a good traction. So this is the same situation as the laparoscopic surgery where the assistants hold this target tissue, and then we can do this dissection in a distant view. So this is the advantage of having this traction technique during the dissection. And then the other thing is that sometimes as you can see here, the muscle layer can be retracted by this traction force. So we need to keep in mind that sometimes we need to just cut right above the surface of the muscle. So you need to recognize where the muscle is located. So I'm using the clutch cutter right above the surface of the muscle right now. The advantage is that, again, so even there's a bleeding, we can just keep the knife right at the bleeding point and then continue coagulating and dissect through this area. And then also the other thing is that this re-grasping capability and then repositioning capability. So with the clip and band traction technique or other traction method, once it's deployed, we cannot change the location of the traction and also the force and the direction. So this is the biggest advantage of using this articulating device as your right hand. So one of some limitation is that always the track motion comes from the right side channel on the right side on the screen. So if the lesion is located on the right side or 12 o'clock of the screen, sometimes it's hard to use this track motion device. And then we are getting to the end of this submucosal dissection. But usually the end of the ESD becomes very difficult. Sometimes it becomes very floppy. But and then sometimes we get this bleeding. But because we have the traction, we can continue the hemostasis and continue dissecting. So then some oozing, so I'm using the surface of the clutch cutter for the hemostasis. So I thought I need to regrasp the target tissue at this moment. So I just released the target tissue and then put the scope underneath this lesion and then advanced this articulating forceps grasper to regrasp the target tissue. So there's some learning curve, but this is my 5th case, I think. But I was able to use it comfortably. So there's a perforating artery, but we have the traction technology, so we can visualize the target tissue and also the perforating artery. So I'm going to cauterize first using the clutch cutter. Then I'm doing like a 2-point hemostasis, and then switching to the endocut to cut through. So usually at the end, we need to use the cap to stabilize the target tissue, but because we have this traction stabilized, the target tissue is very stable. And then you can see that we only have this small string. So this lesion was approximately 5 or 6 centimeter lesion. And also the other thing is that we can use this track motion device for the specimen retrieval too. So actually this ESD was completed in 15 minutes. The mucosal incision was 6 minutes and submucosal dissection was done in 9 minutes. I'm using the coagrasper. I think I can use the same ESD knife, but I just wanted to make sure. So I switched the device with the coagrasper and using the soft coag for the prophylactic hemostasis. And then I thought this defect is small enough, so I'm using the 16 millimeter Dura clip to close and approximate the mucosal edge. And then I'm using another Dura clip to place another clip here. And then once this defect became smaller, I'm using the 360, regular 360 clip to completely close this mucosal defect. So this lesion was 5 by 4 centimeter lesion. Pathologically, it was the tubulovenous adenoma with high-grade, multiple high-grade dysplasia foci. Okay, so thank you very much. Thank you for your attention.
Thank you, Hiro, for this. That was wonderful. So I think there was one question from the audience about the cost of these devices and how that factors into what you do and how you choose your devices. So any thoughts on that?
Yeah, thank you. That's a great question. So as you can see here, that this traction device is made very well. So it has a articulating capability, and then I think it has a potential to reduce the learning curve if you want to start ESD. And then I think that eventually has a potential to reduce the procedure time. So basically, this device costs about over $2,000. So, and then also you need to use the double channel endoscope. So it's from the cost perspective, like a device cost, it's a little costly device. But considering the duration of the learning curve, and also we can reduce the procedure time, it has a potential to be able to use during some beginning of the learning curve for the ESD.
Thank you. And that brings us to one more question. And I think in the interest of time, we'll just take this one question and then move on to the next case. So the question is it always mandatory to close mucosal defects following ESD in rectal lesions?
Oh, that's a great question. So, so basically, I do not close the defect at all. I usually take probably 10 or 15 minutes for the prophylactic hemostasis to prevent the bleeding. And then most of the case, I usually probably 98% of the case, I usually leave the mucosal defect open. So this is this case was just, the defect was small enough. So I used the clips to close.
All right. Very good. Thank you again, Hiro.